The diagnosis of multiple sclerosis is usually given by a set of criteria, and we call this criteria the McDonald criteria. This criteria has been set up over the years to allow us to include not just the clinical manifestations of MS, but also other supporting data, including MRI, including spinal fluid, things like that. When we talk about the diagnosis, we are looking to make it as early as possible, and to accomplish that, we will look at patients when they present with their first event. That first event might be something like an optic neuritis or maybe a transverse myelitis or something like that. And at that point, you'll do the workup. And the workup may include an MRI scan, it may include spinal fluid, and you may define this person at this point as clinically isolated syndrome. When they get the MRI scan and you see that there are a number of lesions in the brain, you might be concerned that this has been going on. So these are more than one event, even though clinically they've presented with one event. But their manifestations on their brain MRI may have told us that there's a number of things that have been going on silently. So the McDonald criteria were developed with the idea that can we use the MRI scan to give us a piece of information that patients did not experience clinically, but there was subclinical activity. So if we see multiple lesions separated in space and in time, that is what is required to make a diagnosis by the McDonald criteria. And this iteration has evolved over the last couple of decades. We've had some in 2001, 2005 modifications all along the route, and now in 2017 we have the most recent version. And what it has allowed us to do is to make a diagnosis as early as possible. So you could make a diagnosis of clinically isolated syndrome patients after one event if they meet certain criteria on MRI and or spinal fluid. If they've got a number of lesions that some are active and some that are not active, so that gives us a time component, because we know that activity on a MRI scan may only last about a month to 6 weeks. But if they don't have the activity metric, but they have space, meaning you see multiple lesions, they've had one event, you now can utilize a spinal fluid analysis if they have positive oligoclonal bands that will fit the criteria for time to allow us to be able to make a diagnosis. And there are a couple of other changes, including things such as cortical lesions can now be used to allow us to make a diagnosis. And in addition to that, you can look at the MRI scan and you can see that there would be lesions that would be symptomatic of the event that's happening at this time. You can now use that symptomatic lesion to include as a possible diagnostic criteria.
The most recent 2017 revised McDonald diagnostic criteria actually have not significantly changed my practice at all. I would just say the following. I originally didn't like the diagnostic criteria. Early on, I thought they were too complex, but I like them now. I think they have really, in the number of revisions, gotten much better. I think everybody should be using the 2017 McDonald diagnostic criteria if they're making a diagnosis of either relapsing or primary progressive MS. I think there should be a comment on whether they meet those criteria. What we really need are radiologists and neuroradiologists to buy into that. If we're doing an MRI scan for a potential diagnosis of MS, I think they need to be referring to the McDonald diagnostic criteria. And the one place where I do use them is there are two ways by the diagnostic criteria to make a diagnosis of MS, even though there's only been one attack, a clinically isolated syndrome. If you meet the MRI dissemination in space and time, and if you meet the MRI dissemination in space and they have positive CSF-specific oligoclonal bands. So in those two instances, even though there's only been one attack, I will say this person meets the formal criteria for MS. So that's probably the most popular way that I'm currently using them.